What are the solutions? How can we help people with mental illness so that they don't hurt themselves or others?
The good news is it's all fixable. We don't need a huge amount of intensive research to know how to have an impact on the out-of-control failures of mental health.
There are a myriad of options, ranging from least to most restrictive. Among the least restrictive is crisis intervention training, also known as CIT.
The point of CIT training is to help police officers and respondents deal with mental health crises in the most compassionate manner possible. It often means de-escalating the situation where someone is really agitated. It means trying to get them to divert them from jail and divert them from the hospital even, to use other community resources.
The first crisis intervention training we did, almost every cop in the place was made to go. They didn't want to be there. I'm a cop. I'm not a social worker. I don't believe in hug-a-thug programs anyway. By the end of the week, they were all loving it. In fact, the police chief, here is the first police chief in a big city, is requiring the 40-hour training for all his cops. I believe Santa Fe's kept statistics, and they've had a reduction of SWAT team call-outs. So the more officers they have trained, the less SWAT they have to call out because they're de-escalating things and they're not making things worse.
Some people point to the need to build strong patient-doctor relationships.
What we need is more community-based care that is based on a recovery model and is based on a client-centered approach that encourages alliances between the individual and the treatment provider, so that when the individual starts feeling alienated from society and starts ruminating about things that he or she might do to others, the treatment professional has an idea of what's going on because this therapeutic alliance has been formed.
It doesn't take neurologists on every street corner. It often takes something as basic as having a case manager who does routine home visits and helps you pay your bills and helps you apply for benefits and helps you navigate the challenges of community living.
Another option is to forge an agreement with the person who has mental illness, where he authorizes care when his condition deteriorates. Laws permitting these agreements vary from state to state. These are known as Psychiatric Advance Directives, or Ulysses contracts.
It's not really a contract, it really is an advance directive. Just like you might have a power of attorney for health care for your regular medical care, but this is specific to psychiatric illness. And so you might say, appoint someone as your power of attorney for your mental health care. Somebody can say, look, when I start heading down that road where it looks like I'm going to have a relapse, I want you to intervene early and get me stabilized on my meds, do what you have to do, whether it's an outpatient commitment or take me in to get me seen, before I reach this level of dangerousness or things like that. So it's an attempt to, really twofold, prevent the negative consequences, the horrible, horrible, devastating effects that mental illnesses have on people. And two, it really, going back to the notion of liberty, it's respecting the liberty of people with mental illnesses.
In cases where the patients need more supervision, there is the choice of outpatient commitment. This is an understanding that the patient will be hospitalized if he or she does not comply with treatment.
Virtually every study that's been done on outpatient commitment shows that it works. And the data, we got more studies coming, but the data is quite clear. The outpatient commitment has clearly shown a marked decrease in hospitalization. It has shown a decrease in homelessness. It's shown a decrease in violence. It's shown a marked decrease in jailings on it.
Others point out that some patients are so sick, hospitalization is the only effective option. In those cases, they say, we need to build more beds to make sure that these people can be helped.
When somebody is presenting themselves and saying, I believe I need inpatient treatment, and the reason they're not receiving it isn't because they're not eligible medically, they are. Frequently, they don't get in because we don't have enough inpatient resources, and the hospital's already full.
Events in recent years, like those at Virginia Tech and Tucson, lend an urgency to a need to get help for the sickest and most dangerous.
There's no one silver bullet for every patient. Outpatient civil commitment might work for some patients. Psychiatric advance directives might work for others. And there are still some patients who require inpatient treatment. Some may have such severe psychosis that they might never be released.
What really has to occur is sort of the political will to stand back, and whether you do it for human reasons because it's the moral thing to do, or whether you do it for fiscal reasons because it's a waste of money, the important thing is that we do it.